Hello, everyone. Thank you for joining our presentation today. Um, the presenter will be Michael Postelnick. He's a practice coordinator, antimicrobial stewardship at Northwestern Medicine. Mike currently coordinates antimicrobial stewardship efforts across the NM system and maintains an antimicrobial stewardship and infectious disease pharmacotherapy practice in the system's Northwest region at Huntley and McHenry hospitals. Mike obtained his pharmacy degree from the University of Illinois and completed a residency in pharmacy and pharmacology at Rush Medical Center. Mike began his tenure at Northwestern Memorial Hospital in 1987, where he guided and implemented the hospital's first antibiotic formulary. The formulary efforts spurred the development of the empiric antibiotic use guidelines in the early 1990s, which were used to provide prospective audit and feedbacks to prescribers. These early antimicrobial stewardship efforts were conducted primarily manually, evolved with the development of the electronic medical record and clinical decision support, both of which the program at NMH was an early adopter. He has led the expansion of the program at the Academic Medical Center with the addition of new hospitals to the NM system and has led the development of the NM System Antimicrobial Stewardship Quality Committee, which has worked to implement consistent goals and processes for the antimicrobial stewardship effort. So thank you so much, Mike, for doing this presentation.
Thank you. Thank you very much for that introduction. I've been very fortunate in my career. Obviously, I've had a very long career, and I've been fortunate in a number of ways. One of them being the fact that I've been able to practice at the same institution for the vast majority of my career, and that practice has been in infectious disease pharmacotherapy and antimicrobial stewardship. So that gives me kind of an interesting perspective to look at how stewardship has developed over the years. And I've obviously, having done that, tried a number of different things, some of them successful, some of them unsuccessful. And anybody who knows me knows I have a lot of opinions about antimicrobial stewardship. So what I'm going to do over the next 45, 50 minutes or so is share some of my experiences with you, give you my opinions on what the keys are to sustaining antimicrobial stewardship over the years, and hopefully provide you with some things that may not be immediately useful, but the experiences may help provide you with food for thought in the future as your programs begin to develop and mature over time, and as the importance of what we do continues to grow. So anybody who watches regional sports networks and such with their commentators know they usually provide 3 keys to the game prior to the game to determine whether your home team is going to be successful or not. I tried to think of that in terms of stewardship, but I couldn't narrow it down to 3. But I do have 10 keys to what I think are key to victory in sustaining a stewardship program. One is to know the history of why we're doing antimicrobial stewardship. How did we get here? Where do we want to go? Secondly, learn your organization. You have to know your organization. You have to know the decision makers. You have to know the audiences you're playing to. Because when all is said and done, stewardship depends on your ability to influence people. Influence prescribers, influence administrators, influence regulators. So you really need to know who is who and how to go about doing that kind of influencing. Develop relationships, both internal and external. Along with learning your organization, you need to develop relationships. Medical staff relationships, prescriber relationships obviously are keys to improving antimicrobial use. You also need to develop relationships with the quality people in your organization, because they're going to be tremendous helps to you in terms of getting things done. Because when all is said and done, antimicrobial stewardship is a quality improvement effort. And you need to develop relationships with administrators, not only who you directly report to, but administrators throughout the hospital, because again, being able to share your message is going to be something that's really, really important to the success of your program. And then there's the external relationships, and we'll talk a bit about those in a future slide, but I think they're very important to your professional development and to the development of your program. Know the standards. Standards are our friends. The Joint Commission standard and the CMS rule has both of those have provided us with the basis for our being, and our organization is pretty much mandated to provide support for us. Now, how much support and how effective that support is totally up to how effective you are in presenting your case. Benchmark effectively. When I started in the stewardship game, benchmarking was very difficult. Fortunately, it's gotten easier over time. NHS and AU has really been a big help in terms of benchmarking, and we'll talk a little bit about some of the ways to utilize those data. Speak the language of the decision makers. We like to speak clinically because we are clinicians. We like to speak in terms of science and in terms of outcomes, statistically significant results and studies and such, but that's not necessarily the language of the decision makers. They're looking at other things, and they're definitely not going to sit through a 25-slide presentation on the clinical data that makes what you do relevant. So you need to know their language, you need to know what's effective, and you need to be able to present your case in a way that they will listen to. Build your team. Stewardship is a team sport. You have to have a good stewardship team, but you also need to include many others across the healthcare organization as your team to get things done, because the stewardship group by itself can't get it all done. You need to enlist important other contributors to improve antimicrobial use and to recognize the importance of improved antimicrobial use. You have an effective communication plan. You need to do that both for decision makers and for clinicians. How you communicate your recommendations is going to be really important in terms of determining how effective those recommendations are going to be. You need to be nimble and look for opportunities. Some things that you might not think relate to your core mission actually may be an opportunity for you to bring the skills of the stewardship team to the forefront. So never overlook a potential opportunity, and don't be stuck in a rut, and be willing to go outside your comfort zone. And lastly, be passionate. What you do is important. Project that passion. So starting with knowing the history, may interest you to know that the first antimicrobial steward was the father of penicillin. Sir Alexander Fleming, this quote from him is one of my favorite historical quotes over time, and I think you can just change the name of the drug and use the same quote. The thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with a penicillin-resistant organism. And we've seen that play out time after time with antimicrobials. We get a new antimicrobial, we use it to death, it becomes resistant, we use it in a lot of situations where it's not appropriate, and we end up losing its effectiveness. So Sir Alexander Fleming foresaw this, and in this quote, he clearly lays out a statement that everyone should heed very closely. So there were a bunch of early papers that were published that alluded to how antibiotics were misused. And you can see as early as 1957, we had a paper published in the New England Journal of Medicine that talked about misuse of antibiotics. And there were a number of other publications through the 70s, culminating with Cal Coonan's editorial in the New England Journal here from 1979. And there's one particular quote that I really like to pull out of this, and it's that antibiotic usage conjures up an image of fallout akin to that from a leaking nuclear reactor. There's legitimate concern about the development of antibiotic resistance and its transmission by plasmids as the result of excessive antibiotics. So how antibiotics are different from other drugs. If you give somebody an ACE inhibitor, you're not going to make subsequent individuals treated with ACE inhibitors resistant to them just because this previous patient used an ACE inhibitor. However, with antibiotics, that's not the case. So one always needs to take into account the collateral damage caused by antibiotic use. And that's what we do in terms of antimicrobial stewardship.
Hi, Mike.
So what
Sorry,
about the money?
Mike, sorry to interrupt, but it looks like your slides aren't advancing.
Can I ask, can everybody still hear me?
We can hear you. Your slides just aren't advancing. Okay, now we're on what about the money?
Okay, I think I'm going to have to exit and come back in.
Okay.
I'm so sorry about that. Can everybody hear me now again?
Yes, we can hear you.
Okay, great. So moving on to what about the money?
Are you sharing your slides?
I am. Can everybody see them or not?
No. Rachel, do you have a copy of his slides that maybe you can share?
Let me look at my email.
Let's see here.
I can send.
Can people see slides now?
We see your screen?
Okay, and can you see the slides?
No, we just see the session itself.
Okay.
Rachel, I just sent you the slides if you wanted to try to screen share.
Yes, I just got that.
Sorry about that, everybody. Any luck, Rachel?
Yeah, I'm just pulling them up. They're still
Okay.
taking a while. I'm sharing it. Are you seeing it?
No.
No, we're not seeing it.
Well, now.
No. I can try to share them. Can you guys see the slides now?
Yes.
Okay.
Okay.
And is it full screen?
Yes.
All right. What slide were you on?
Okay, if you can keep going down, Shannon, I'll let you know where we're at. Up a bit. Up a bit.
Backwards?
Backwards. Yeah, back to the top. I'm sorry. I'm sorry. Keep going. There we go. That's it.
What about the
Okay.
money?
What about the money?
Okay.
Okay. So back to where we were. What about the money? So the initial papers published were talking about appropriateness of antibiotic use, but it was soon evident that there was potential cost savings to be had there. The time I started in antimicrobial stewardship, antibiotics were the second or third highest expense for pharmacy departments in hospitals. So there clearly was an opportunity to, if we went towards more appropriate antibiotic use, to actually increase or decrease expenditures. And there were a number of papers published in the 80s that looked at how we can decrease expenditures with antimicrobial stewardship. And antimicrobial stewardship, which wasn't called stewardship at the time, became very important opportunity for hospital pharmacies to save money. Next slide, please. And then there was public awareness. And in the mid-90s, there were two cover stories published, one in Newsweek, one in Time, about the potential crisis in antibiotic resistance. And this was about the time it became clear that the antibiotic pipeline was drying up. Companies were stopping research into new antibiotics, and resistance continued to grow. So it became clear that this was going to be a problem in the future, and this was the first indication to the public that there's going to be a concern with antibiotics. And if you went to any presentation on antibiotics in the late 90s, you would almost always see these covers as a lead-in to discussions of antibiotic resistance. Next slide, please. So these issues prompted the professional societies to start looking at guidelines for antibiotic use. And the first attempt at those was by the Infectious Disease Society of America in 1988. And that was the guidelines for improving the use of antimicrobial agents in hospitals. And those guidelines actually set out a lot of what we currently still do in antimicrobial stewardship. They made clear the issue of poor antibiotic use and the risks and how we might go about making it better. The next guideline released by IDSA was in 2007, and this began routine use of the term antimicrobial stewardship. and laid out a program for how you could develop a stewardship program in a hospital. So this was kind of a step-by-step in developing a stewardship program and what are the important points of a stewardship program. The actual development pieces came together a few years later with the core elements from the CDC in an update to the IDSA stewardship guidelines, where core elements clearly laid out what was expected of a stewardship program to, in fact, have an impact on antibiotic use. And this was pretty much echoed in the IDSA recommendations. Next slide, please. And the problem continued to be in the eyes of the public, and actually the White House Forum on Antimicrobial Stewardship in 2015 was a big catalyst to a lot of where we are now. This was a meeting of decision makers that got together, over 100 individuals involved in antibiotic use and antibiotic stewardship. And from this and another meeting on antibiotic resistance, there came an action plan on how we should go forward to make sure that we maintain antibiotics as a useful resource and work to decrease the development of resistance. Next slide, please. So this prompted the regulatory agencies to get into the fray, and standards were developed. In 2017, the first Joint Commission Antimicrobial Stewardship Standard went into effect. This laid out what was expected of all acute care hospitals, as well as critical access and nursing care centers, when it came to antimicrobial stewardship. And this was a big catalyst to the development of new programs. Prior to the standard, the percentage of hospitals that met core element requirements for stewardship was very low, somewhere in the 30% range. And afterwards, we've gotten now to the place where we are now, where self-reported around 90% of hospitals meet the core elements for stewardship. The CMS followed up to the Joint Commission standards, and it took them a little while, but in March 2020, this rule on antibiotic stewardship programs became effective. Stewardship is tied with infection prevention, and I think that's very appropriate. Infection prevention is really our older sibling. They have many of the same goals, gone through many of the same issues we've gone through in our development, and they're really important group to ally your program with. So our rule is found ingrained with the infection prevention rule. And actually, just at the end of last week, interpretive guidance for the CMS rule was released. So you really should access that and take a look at it and make sure your program is meeting what the CMS expects from you, and use that interpretive guidance to help you explain to your accreditation people if you may need help in terms of getting extra support or resources. Next slide, please. So I've been at NMH for a long time, and obviously my ASP experience has been at NMH. So what I'd like to share with you in the next 10 minutes or so is just kind of go through the progression of stewardship at NMH and some of the things we did, and hopefully that might give you some appreciation for where we were and stimulate some thought for where you might want to go with your stewardship program. Next slide, please. So when I was hired in 1987, I was given two direct charges. One was to develop an antibiotic formulary. NMH did not have a formulary at all. In the first place that the organization decided they were going to start was with antibiotics. So that was my first charge. And my second charge was something that was very contemporary in 1987. And that was develop an aminoglycoside dosing service. Our clinical pharmacists were very integral in the dosings and the safe dosing and monitoring of aminoglycosides through the 80s and a large part of the 90s. This service that we developed was meant to include all pharmacists at NMH. So we developed a training program that focused on not only on aminoglycoside pharmacokinetics, but also on the clinical monitoring of antibiotics, looking at appropriateness of therapy, clinical progression, renal function, how to integrate culture and susceptibility results. In this training, we put to good use a couple years later when we rolled out our first set of antimicrobial use guidelines. And this helped us have a good group of trained pharmacists to be able to implement those guidelines. Next slide, please. So between 1990 and 2000 was, for our stewardship program, the paper era. Some of you may remember, most of you probably don't remember, back to the paper chart era where everything was on paper and nothing was, for the most part, electronic unless somebody took it from paper and put it into an electronic system. So that was what we were operating with when we started this, and we made a number of interesting steps to make this happen. Next slide, please. The first was the development of empiric antimicrobial use guidelines. We went the long road to do this, and we started with the antimicrobial subcommittee, and we developed a indication-based, organ system-based empiric antimicrobial use guideline document. And that document included site of infection, the type of infection, some clinical pearls, likely organisms, and what the recommended empiric regimen was, as well as the cost per week associated for that regimen. The committee developed these, and then before we rolled them out, we sent them to every clinical department in the hospital, the chairs and chiefs of all the departments in the hospital for their review and feedback. We solicited their review, we reminded them to review, and we did get a fair amount of feedback from them on the guidelines. We carefully considered and incorporated a lot of that feedback in the guidelines and then sent them back for final approval to the same group. By doing that, we got broad buy-in that these antimicrobial guidelines were appropriate for the organization, and that the chairs and chiefs would be helpful in terms of spreading that message and helping to enforce these guidelines across their various staffs. So it took us about 2 years to get this done, and finally in about mid-1990 we rolled out these guidelines. Next slide, please. When we rolled out these guidelines, we also rolled out a tool for pharmacists to review antibiotics. We did have an antibiotic order sheet at that time, and order sheets were developed, and it was relatively common practice in the 80s and 90s to help guide prescribers to think carefully about antibiotics before they ordered them. The guidance was meant for to help pharmacists evaluate the orders and then document that evaluation. And they actually did that documentation directly on the antibiotic order sheet. We tried to make it as simple and quick as possible, knowing that unit-based clinical pharmacists didn't have a lot of time. So we made simple yes-no questions regarding the antibiotic order that they received. Was the dosing appropriate? And if it was an empiric order, was it appropriate based upon the guidelines? And if it wasn't, did they intervene to make the change? We collected every antibiotic order sheet on a monthly basis, and then we tabulated the data. With those data, we prepared monthly reports and submitted those to medical staff quality committees. Next slide, please. This is an example of one of those reports from 1991, and basically it was kind of a pass-fail for dosing and appropriate use sent to each of the various departments in the hospital for them to feed back to their prescribers. They weren't utilized extensively universally, but there were a number of departments that really did feed this information back to their prescribers and did, again, reinforce the guidelines to make sure that those guidelines were used. These are also sent to the hospital quality department as another measure of prescribing quality, and we did utilize it even though this was prior to Joint Commission stewardship guidelines. We did use it as a measure of an ongoing DUE. Next slide, please. So we did that for about 10 years. It progressively got more difficult as the hospital got busier, more beds, without a lot of increased staffing. But we tried to maintain it as much as we could. And the clinical pharmacists did a fantastic job of being on top of antibiotic therapy. And it was a strong focus of everybody's work at NMH during that time. And from 2001 to 2005, we moved on to the CPOE era, which did complicate issues. Next slide, please. We were early adopters of CPOE, but it was phased in. So we had a mix of computer order entry and physician order entry. And that did complicate our ability to continue to provide these quality reports, because for electronically entered orders, we had no way to document our assessment easily and to retrieve that documentation. The guidelines remained in force, but the adherence to the guidelines were difficult to track. The optimizing book, which I'll get to in a little bit, was basically the Bible of antibiotic use, and we produced a pocket book on an annual basis with the revised antimicrobial guidelines and other clinical pearls for clinicians. It was much sought after by house staff and actually attending staff as well, and we distributed upwards of 500 copies a year. So that was our mechanism of communicating these recommendations to prescribers. But as we went on with CPOE, scope of our ability to feed back results to prescribers was minimized. Next slide, please. This is a later optimizing book cover. Basically, the optimizing medication use NMH book was prepared by the stewardship team, the antimicrobial subcommittee, and the pharmacy and therapeutics committee. And it took us a couple months every year to prepare this. It was reviewed extensively by the committees before it was released and sent off to a publisher, and was published and came back, and then we began distribution. We tried to time these changeovers with integration of the new house staff, which was obviously early summer. So this was our method of communicating our guidelines. Next slide, please. So from 2006 to 2017, we moved further to CPOE and eventually had universal computerized physician order entry. And then we moved on to getting also the ability to have electronic clinical decision support. Next slide, please. So as I said, we fully implemented CPOE. About 5 years after that full implementation, we actually were able to implement required prescriber documented antibiotic indications, which at that time was a heavy lift, but with the assistance of our quality colleagues, we were able to push that through. We were an early adopter of add-on clinical decision support for stewardship. We were actually one of the first sites in the country to add Theradoc to our armamentarium, and it became our primary tool for antimicrobial stewardship. It expanded our breadth and scope and simplified restricted drug monitoring and really helped target our audit and feedback program. Next slide, please. This is a screenshot of our initial antibiotic indication list, which went into effect sometime around 2012. Prescribers were not able to enter an antibiotic order without selecting an indication. These indications became extremely helpful for stewardship. We were able to target certain indications, certain sites of infection. We were able to audit them. And they were very helpful in day-to-day interventions because we had a sense for what the antibiotics that were being ordered were actually being used for. Next slide, please. This is an example of a very rudimentary restricted drug alert for meropenem. And with the advent of Theradoc stewardship, the stewardship team became more involved in monitoring restricted drug access and making sure that the restrictions were being upheld. Next slide, please. We progressed to actually, this was our worksheet in the antimicrobial stewardship, which we would use for various restricted drugs, and we were able to pull directly notes that pharmacists put in regarding their interventions regarding those drugs, and able to audit how well we were doing in maintaining those restrictions. With the advent of Theradoc, we were able to go back to getting some feedback from our clinical pharmacists on antimicrobial use, and it was very helpful to continue to push forward our stewardship efforts. Next slide, please. We're also able to build alerts by ourselves, which was really a big plus to the system. De-escalation logic was not initially included inside Theradoc, so we were able to build these alerts and able to this one, we were able to actually reduce our Zosyn use by about 20% over a year by the implementation of these alerts, which would fire directly to the floor clinical pharmacists and clue them in as to when Zosyn could be de-escalated. Next slide, please. This is just another shot of the Optimizing Medication Use book, which continued to remain the focus of what we were doing in stewardship. Next slide, please. So that moves us on to kind of the current era, 2017 to the present, where we went to a different CPOE system and integrated clinical decision support. Next slide, please. So in 2017, the hospital decided to change their EMR vendor. They went from Cerner to Epic. And at that time, we were told that Epic will be able to do everything that Theradoc could do, so we had no further need for Theradoc. So when we transitioned to Epic in 2017, Theradoc was shut down. Unfortunately, when we went live on Epic, it was for the most part non-functional. And this is probably an important example of how you need to continue to be engaged with IT to make sure you have the best tools for stewardship. So we lost most of our ASP capabilities, and we continue to bring this forward to IT, and they were unable to rectify it. And we finally got to the point where we were able to demonstrate the impact on the stewardship program, our inability to monitor antibiotics, how that was affecting patient care, and our ability to identify bug-drug mismatches, intervene on inappropriate antibiotics. And we finally got the organization to agree to either hire a consultant to fix Epic or to bring back Theradoc. Of course, they went to stick with Epic. They hired an IT consultant, but that was a very successful move. We underwent a 9-month project that ended up giving us actually enhanced capabilities for stewardship. Next slide, please. This is an example of our current stewardship dashboard. It provides information at a glance for patients on antibiotics. We have a scoring system for antimicrobial stewardship. The scoring system isn't perfect, but it does provide some rudimentary information to help identify patients who might best benefit from a stewardship intervention. And it also provides alerts for bug-drug mismatches, de-escalations, drug lab mismatches, patients on broad-spectrum antibiotics and unrestricted antibiotics. And the antimicrobial stewardship pharmacist could actually sort on those columns, bring to the top of the list patients who meet those criteria, and intervene on those criteria. Next slide, please. This is a screenshot of the information panel that the stewardship pharmacist can use. Brings together all anti-infective data at a glance, clinical data, current drug therapy, access to the stewardship navigator, which I'll talk about in a minute, and provides detail on why some of the alerts fired and what the intervention potentially could be. Next slide, please. This is a screenshot of our current stewardship navigator, and this is where the documentation for antimicrobial stewardship occurs, starting with the type of intervention, and those intervention types that can cascade to text boxes where the pharmacist can document details of their intervention. The medications, obviously, check off boxes for those. If we're doing an empiric antibiotic assessment, whether it's appropriate or inappropriate, and then the indications can be documented there, along with anything else we want to document in overall recommendations and who we contacted in terms of our intervention. But probably most importantly is down at the bottom, the send BPA to provider after a progress note is placed. One of our most effective communication methods is using the BPA. So when a prescriber goes into a patient chart and the stewardship team has a recommendation, the BPA will fire. We try to put details of the recommendation directly in the BPA, but we don't. The BPA won't fire unless we have a progress note in where we detail our rationale about why we're making the recommendation, so the provider can then consider the thought process behind the recommendation. We find this to be very effective, and I'll talk about it a little more in a future slide. Next slide, please. So, learn your organization and develop relationships. Next slide. So I apologize for those of you who aren't into football analogies, but I think they're appropriate here. Let me indulge me as I go through these. The clinical pharmacists really make up your team, your entire team. Without them, you don't have a stewardship program. The hospital administrative support is like the team owner. They provide you with the resources to be able to do stewardship. The infectious disease pharmacist and physician is like the quarterback. You set the direction of the stewardship program. You provide the resources, tools for the team members to be successful. And the microbiologist is kind of like the strategist for the team. They provide the data that you need to be able to impact effective antimicrobial stewardship. Next slide, please. There are other important stakeholders. I mentioned previously, infection preventionists should be somebody you value as colleagues and team members because, again, our missions are very similar, and the CMS lumps us together, so we need to be very cognizant of that. I think an underutilized resource is the bedside nurse, and we should strive to make bedside nurses more involved in antimicrobial stewardship. They're at the bedside when decisions are being made, and I think there are certain components of the stewardship program that bedside nurses are very much suited to accomplishing. Information technologists, very important, as you can see from our struggles with getting data when we went to a new EMR system. Without good information technologists, doing the job of antimicrobial stewardship becomes very, very difficult. And then quality assurance and accreditation are two groups that you should be very, very friendly with. The collaboration with quality assurance is required in Joint Commission and CMS standards. And the accreditation coordinator is very important to helping you, making sure that you meet all the standards and have all the resources to be able to do that. Next slide, please. And not only internally, but relationships outside of your program are important. Establish contacts with other local and national antimicrobial stewardship practitioners. This is what will really make your job rewarding. Best ideas come when you share them with people who are like-minded and have like responsibilities. So I have to say that a lot of the best things that I have been able to do in antimicrobial stewardship has come with collaboration with my colleagues around the country. So don't pass that up and become involved so you can do that. Participate in local, regional, national conferences like you're doing right now. The Illinois Antimicrobial Stewardship Summit is really a great opportunity to get new ideas, to network. And we hopefully will be able to go back on site, and that even enhances those opportunities for networking. Professional society meetings like ID Week, SHEA, and ASM, as well as SIDP, allow you the ability to network and get involved in organizations that promote stewardship, like SHEA, like IDPH, like IDSA, and SIDP. Next slide, please. Know the standards. Next slide. You should be the most knowledgeable person in the organization regarding the antimicrobial stewardship standard and CMS rules. Next slide. So be the recognized expert. Get to know your compliance coordinator, who should be your best friend. Work together with your compliance coordinator to make sure they know that you're on top of the stewardship standard and that you have things in place to make sure that the accreditation visit goes very, very well. Stay on top of proposed changes. You should be the first one to know about changes in the stewardship standards. Professional organizations are good sources for that. Also, the social media like professional Twitter, a lot of these things get posted very quickly when they're available. So keep on top of those. Be proactive when those changes occur. Be on top of it, make the changes. And I think lastly, it's important to look at an accreditation not as a threat, but an opportunity. I think if you're on top of the standard, you have things in place, you are able to develop a document that is organized according to the standard and documents everything you do to meet the standard, the accreditation visit becomes very easy because the accreditors will review that document before accreditation. If they find that you meet all the standards, basically what they'll give you the opportunity to do at the meeting is to highlight what you do well, and you're able to give your elevator speech about what stewardship's doing, why it's important, and all the good things that you do. So accreditation shouldn't be looked at with trepidation unless you haven't been on top of things over the years. Next slide, please. Benchmark effectively. Next slide, please. Benchmarking is really, really important and is something that was really difficult until NHSN developed the AU. I think with the AU now we have a reliable standardized benchmark to help us look at how well we're doing with controlling antimicrobial consumption. What you need to do as a steward is present these data in an understandable manner. When you're presenting it to non-stewardship colleagues, you need to be able to explain what a SAR is. Administrators do understand observed to expected ratios, but they understand better when you provide a frame of reference and look at how you're doing compared to the competition. And that's where the SAR percentile rank becomes even more important. And we've gone almost exclusively to using the SAR percentile rank when we report our performance, because that gives us the perspective of how we're doing in regards to the rest of the country with our antimicrobial consumption. With those data, you have to look at what intervention should they drive. Are you overusing broad spectrum hospital onset antimicrobials? So what can you do to intervene to help drive those numbers down? Are the community acquired broad spectrum agents being overused? So what's happening there? Is it durations of therapy? Is it antibiotic choice? Those are the things you need to, that the NHSM data gives you direction on what to dig into. And then when you develop these interventions, you have to determine how you assess the outcome of these interventions. Next slide, please. So we utilize, as I said, the SAR percentile rank. We've developed a report in our electronic data warehouse that tracks monthly numbers as well as trends. This is an example of the all anti-infective data. Next slide, please. And this is previous slide. This is the broad spectrum hospital onset SARS, and by tracking trends, we're able to see how each hospital is doing and where there might be some help needed and help them develop interventions to make those changes. Next slide, please. So how do we assess effectiveness? We utilize the Stewardship Navigator to document our recommendations and the acceptance rate of those recommendations. This is just an example of 1 month's worth of data. Next slide, please. And we track trends on those, and we work to maintain an acceptable range of intervention acceptance. In these data, we're considering over 75% to be acceptable. If we drop below, we look at working with some of our stakeholders like hospitalist leadership and present information to them about the types of interventions we're making and what goes into those so that they understand why they're well thought out and deserve to be considered. Next slide, please. This shows just the acceptance rate for an area that we're targeting, and that's respiratory indications. And we track this again on a monthly basis. This is 1 month's worth of data, and look for potentials if we need to intervene. Next slide, please. Speak the language of the decision makers. Next slide. So no matter how much we try, and I am the first to say that antimicrobial stewardship is about improving patient care, about quality, about patient safety, resources are about the money. And you have to realize that if your program is going to get more resources, that means there's going to be a program that's going to get less resources. So you need to effectively make the case about why your program deserves more resources. Money is one way to do that. You can talk about real decreases in expenses like cutting antibiotic costs, but unfortunately, antibiotics for the most part now are cheap. So even if you cut consumption, there's not going to be a huge decrease in expense. You can cut supply costs. IV to PO is one way to do that, and one way we kind of forget about that when you change a patient from IV to PO, not only are you decreasing the cost of the drug, you're decreasing cost for the piggyback, you're decreasing the cost for tubing. So there's a significant cut in supply costs beyond just drug when you switch a patient from IV to PO. The other way you can look at this is increasing revenue. And when we talk about some of the newer diagnostic interventions like rapid diagnostics, there's the potential to shorten the length of stay when that's combined with stewardship involvement. So that could potentially result in an increase in revenue for the hospital. And that's something that needs to be looked at a little more closely as we move forward when we're looking to add resources, and it's definitely a potential. Avoidance of penalties, it's important. We've utilized that as we've taken ownership of Idph and been able to demonstrate that we're able to help avoid penalties. And also maintaining accreditation, although that's a relatively low bar, it's still important to the organization because without accreditation, they can't open the doors. Next slide, please. Pitching to the C-suite, I think one of the things we again forget is the importance of being able to speak the language of the C-suite when we're talking to them. This is a great reference for that. It provides insight into the thought processes that occur in the C-suite and can help you formulate an effective presentation. Next slide, please. This is an example of a successful stewardship FTE request we did a couple years ago at one of our system hospitals. We coupled together a lot of pieces to show that the bottom line, to add a stewardship pharmacist is not going to be very costly to the organization. We were very conservative with these numbers. We showed a total cost avoidance of $80,000, but we didn't include a few things. One of them being the avoidance of penalties and the other being length of stay reduction. When those were added on, the total cost avoidance was much, much higher than $80,000. And the decision makers in the C-suite were willing to consider that, and they actually did approve the addition of an FTE pharmacist at a hospital that did not have a dedicated stewardship pharmacist. Next slide, please. Build your team. Next slide. I include a picture here of my colleagues across the system in antimicrobial stewardship. They're obviously super important to making this happen, and the quarterbacks of the team, but obviously you need everyone else. You need clinical pharmacists, physicians, nurses, infection preventionists, microbiologists, and information technologists. You need to bring them all together to have a successful stewardship program. Next slide, please. You have an effective communication plan. Next slide. We talked about communication to individual patients. Establish a strategy that's consistent across your hospital. Not all interventions require a phone call or a page. Those can be disruptive to provider workflow and are not conducive to thoughtful consideration of recommendations. Obviously, there are some emergent situations you're going to have to do that, but a large number of stewardship recommendations can be made in a less disruptive manner. What we found is the BPA is very effective in conjunction with the progress note. There may be other ways that might be effective in your organization, but think about how you communicate those recommendations. Next slide, please. We develop a standardized progress note where the recommendations are at the top of the progress note. We pull in some labs and micro and vitals, and we provide the appropriate disclaimer about our review so that it's clear it's not an ID consultation, it's a stewardship review, and the limitations of what we did review in this. Next slide, please. Rapid diagnostic interpretation is very important. If you look at this, most generalist prescribers will have a great deal of difficulty interpreting this BCID result. This is where the stewardship program comes in. This is an example of a result for an ESBL organisms. Next slide, please. And what you can do with the data from the BCID is basically, if you looked at the resulting dates, we could have had the patient on appropriate therapy 2 days sooner than if we would have been waiting for these culture results. Next slide, please. So as far as communication around the hospital, make sure you have a seat at the table. Get yourself on committees where there are heavy antimicrobial prescribers so that you can provide information and feedback to them, work closely with medical leadership, and continue to leverage the Pharmacy and Therapeutics Committee process. Next slide, please. And you need a strategy for broad communication. I talked about the optimizing book and what we did in the pre-electronic era. What we've done now is we've moved to a website. This is a public-facing website with a very simple web address, asp.nm.org. It's available outside the hospital firewall, so prescribers can get on their phones. They can get it wherever they are. And this provides up-to-date information regarding ongoing stewardship initiatives, important late-breaking data like COVID resources, and hospital-specific antimicrobial resources in the Antimicrobial Resources tab. Next slide, please. Be nimble, look for opportunities. I think, next slide, please. You have to be willing to get yourself out of your comfort zone. When COVID hit, I don't think a lot of us thought of COVID as something that antimicrobial stewardship had a lot of potential intervention or support to provide outside of some of the routine day-to-day stuff. We took on at NMH the fact that there was basically no evidence for the treatment of COVID, and good and poor evidence was being made available almost on a daily basis. So we took on as our role to be the evaluators and interpreters of that evidence, and develop recommendations based upon the evidence regarding place in therapy and contraindications, and laying out the evidence for prescribers. In a matter of weeks, we became the go-to source for COVID evidence. And we maintained that throughout the first year of the pandemic until other professional organizations started working on guidelines and such. And then we incorporated their guidelines into our use. So that actually raised the profile of the Antimicrobial Stewardship Program and cemented our expertise when it came to these types of situations. Next slide, please. Lastly, to sum up, be passionate. What you do is important. Project that passion. If you're wishy-washy about what you're doing, you're not going to be effective. You have to be passionate, and you have to bring forward that passion. And on to the last slide. Just an example. Be an advocate. Bring it. Be passionate. And that's all I have.
Great, thank you. That was an excellent presentation. I think we are into our break right now. I don't see any questions in the Q&A. I think you covered everything pretty thoroughly.
Okay. Well, thank you. Thank you all so much for attending, and I hope relating my experience over these 20-some years was helpful to everyone.
Thank you. I enjoyed the presentation for sure. All right, everyone, you can move on. You can take a quick break, and the next sessions will be starting at 3:45.